Dear colleagues, thank you very much for inviting me to your conference. We are going to discuss research results in this new era of breast cancer diagnosis and treatment. The first breast cancer was published about 5,000 years ago. Unfortunately, during the past 50,000 years, most of the breast cancers that were presented to physicians were very advanced, late stage. It really didn't matter whose wife or daughter the patient was. Bathsheba, the wife of King David, looked very sad, and she died from breast cancer. No funds, no power could control the disease. Fortunately, in the beginning of 1970s, a revolutionary new technique, the low-dose film screen mammography, was invented and put into practice. As a result of it, we experience today a paradigm shift, which can be described very simply. We have replaced the mainly palpable with a mainly non-palpable breast cancer. She already has it, but she doesn't know about it. And that created a paradigm shift, a true revolution. Back in 1986, I founded a research group, and since that time we met twice every year. You can imagine the quality and the quantity of research results. Our most recent workshop happened at the beginning of this year. The best screening experts and biostatisticians are the members of this group: Prof. Stephen Duffy from London, Queen Mary University, Prof. Robert Smith from the American Cancer Society, Prof. Tony Chan and his pupils from Taiwan University. The results I'm going to show are the results of this brilliant brain trust. The group's name is Swedish Organized Service Screening Evaluation Group. Quite recently, we published a quite comprehensive study based on more than 500,000 women, covering about half of the country of Sweden, the results of population-based screening. It clearly shows that the prerequisite for decreasing mortality is early detection. When the woman does not attend screening and present with these advanced cancers, not even modern therapeutic regimens are going to save her life. We are talking about a new era in the diagnosis and treatment of breast cancer, and dear colleagues, that requires an entirely new way of thinking. I wonder what kind of tumor board setup you have. We have 4 screens. The radiologist presents the mammograms and the other imaging, and the pathologist starts to compare the mammogram, the ultrasound, MR with the large 10 by 8 centimeter low power histology image. And finally, we talk about cells, immunohistochemical biomarkers. Basically, all these meetings are all about presenting the cancer according to its site of origin. Constantly compare the large format thin and thick section histology results with the mammographic appearance, called imaging biomarkers. Where does the cancer originate from? From the terminal ductal lobular unit, from the major lactiferous ducts, or from the hybrid cells of the mesenchyme. The diagnostic and therapeutic team members must be familiar with the 4 basic building blocks we teach through using 6-section, so-called 3-dimensional histology images showing the terminal ductal lobular unit that one day produce the milk, the major lactiferous ducts that develop very mean malignant cancers, and also this background, the mesenchyme. 3D histopathology is a very interesting and very efficient tool to teach and understand each other, and also uncover the currently used anatomically totally incorrect, erroneous histopathologic terminology, the ductal lobular dichotomy. The mammogram is nothing else but the black and white histology at a subgross level. When we look into the 3D microscope, this is what we see. The milk factory with its 50, 60 fingers, called acinoid. Dear colleagues, 75% of breast cancers originate from here. About 20% originate from the major lactiferous ducts, and from the yellow background, from the mesenchyme, the breast cancer of mesenchymal origin, once again erroneously called invasive lobular carcinoma, originate from. We strongly suggest a new classification according to the site of origin that helps overcome the inconsistencies in the current histopathologic terminology. We have to make a distinction between the cancers originating from the acini, as you see here. If it's in situ, then the crystals, some homobody-like calcifications, are formed, and it's called grade 1 cancer in situ within the TDLU. Pathologists would call it grade 1 or grade 2 DCIS. Dear colleagues, is this a duct? No. In that case, in 75% of the cases, the pathologist's terminology is incorrect, misleading, and therefore it's harmful. When invasion starts, then we get the stellate or circular lesions with the corresponding 3D histopathology here. An entirely different type of carcinoma originates from the major lactiferous ducts. Once again, these are not ductal cancer in situ, although ductal, but by the time we detect them, they already build side branches. So it's basically duct-forming invasive carcinoma. 20% of all breast cancers belong here, but the fatality rate is about 30%, uncontrolled by screening or modern therapeutic regimens. And this architectural distortion, minimum 5 to 10 centimeter in size at the time of detection, an entire outlier, concave, and it doesn't have calcifications. Imaging biomarkers are extremely reliable predictors of long-term outcome. The success story of screening in decreasing mortality is that we could replace the huge palpable, often ulcerated acinar adenocarcinomas of the breast with the small stellate and small circular lesions. Unfortunately, the cancers originating from the major ducts or from the mesenchyme are still uncontrollable. After 40 years, we can say that we failed to improve the outcome. So in your everyday practice, these are the most frequent, and it's very easy to learn the imaging biomarkers. This is one of our most recent workshops. Have been worked on the imaging biomarkers and their relationship to histology, to outcome, as well as to the immunohistochemical biomarkers, molecular biomarkers. Unfortunately, the imaging biomarkers are underutilized, although they are much better predictors of the long-term outcomes of the most fatal cancers. Prof. Chen gives a talk and summarizes some of the results. Dear colleagues, the whole science is in front of you. If you are an oncologist, pathologist, please learn the third generation prognostic factors, the new era prognostic factors. When the cancer originates from the acini, on the mammogram, it's powdery, cotton ball-like calcifications, grade 1 cancer in situ, not DCIS. Crushed stone-like, discernible, grade 2 cancer in situ. Stellate lesions or circular lesions. Whenever you see a stellate lesion on the mammogram or ill-defined circular lesion, and the pathologist calls it invasive ductal carcinoma, you should smile. Poor pathologist. He doesn't understand anatomy, and that's indeed their biggest problem. When the cancer originates from the major ducts, then the imaging biomarker is simple, very easy and reproducible, but there are 6 of them. Here we had 4. And there is only a single imaging biomarker, the non-calcified architectural distortion for the remaining 5% of the breast cancers. Acinar adenocarcinoma of the breast that originates from those luminal cells that one day produce the milk. There are 50 or 60 acini within one tiny 1.5 millimeter size terminal ductal lobular unit. The ever-increasing pressure is making the TDLU distend and distort still just 3 to 5 millimeter. If we are lucky, we find the calcifications. And please take home the message. This is a totally incorrect term. Whether the cancer cells are within the duct or the TDLUs, the fact is that this is carcinoma in situ, but not ductal. This is ductal, but not in situ, because by the time I find it, there are the side branches, the neoducts. Long-term outcome of the acinar adenocarcinoma of the breast. It really is a fantastic success of early detection and treatment in early phase. The problem with the acinar adenocarcinoma of the breast is multifocality. And unfortunately, multifocality is an independent prognostic factor, whether it is stellate or circular lesion. MR is a must in every single core biopsy-proven breast cancer, because that can tell the distinction between unifocal, multifocal, and diffuse breast cancers. 37-year-old woman, normal mammograms. Fortunately, we are using the multimodality approach. MR shows breast cancer in most of this breast. And indeed, there are 7 foci, and among them there is DAB as well, lymph vessel invasion, node positivity, 8 centimeter region full of carcinoma. We asked the question in the research group whether unifocal or multifocal nature of the disease is going to change through early detection. The answer is no. The unifocal cancer is born unifocal and it only increases in size. Multifocal cancers are born multifocal and one and the other are increasing in size. We did a very good job in population screening. We cut back on the death rate in unifocal cancers. But unfortunately, in 45% of the cancers, 71% of the death occurs. And that's where we should put all of our efforts. One of the diffuse cancers is the carcinoma originating in the major lactiferous ducts. The carcinoma is here, micropapillary, producing fluid. The terminal duct and the acini are totally normal. And there are 6 imaging biomarkers. 4 are calcifications. Necrosis, result of fluid production, or no calcification, bloody or serous nipple discharge, or architectural distortion. Quite a challenge for the radiologist. I cannot understand why the medical community still tolerates the totally mistaken, anatomically incorrect, misleading DCIS diagnosis in cases like these. This is neoductgenesis. There are too many women who died from breast cancer, and they are in the cemetery with DCIS diagnosis, such as this one. Quite a shame in the 21st century. We cannot control about 30% of them. I'm not talking about DCIS, because it's not a DCIS. I'm talking about looking at this imaging biomarker. Dear colleagues, whenever you see a whole lobe full of these casting, rod-like calcifications, you should never accept the DCIS diagnosis and count on it. Quite many of your patients are going to have distant metastasis, even node-negative cases, and unfortunately, 30% are running a high risk of dying from the disease. It is very difficult to understand that the colleagues don't want to buy into the neoductgenesis. The pathologists carry responsibility. They should use tenosyne staining, proving that the cancer cells drilled themselves into the surrounding mesenchyme. They should use large section histology. You see how the cancer cells break themselves through the basement membrane. This is neoductgenesis with desmoplastic reaction and lymphocytic infiltration. Too many duct-like structures, very unnatural. Desmoplastic reaction, lymphocytic infiltration. Yeah, colleagues, this is not DCIS. Neoductgenesis exists in Mother Nature. You have to cut the branches of the bush, neoductgenesis. And the imaging biomarker is very simple. This is the result of epithelial mesenchymal transition. This is the reason why we cannot control it. Stem cell carcinoma. Tenosynovial expression is the evidence of epithelial cell intrusion into the surrounding stroma. An asymptomatic 63-year-old woman. When we look at these imaging biomarkers, we know that there may be a very poor outcome. When you dress up these calcifications, histology is going to show solid cell proliferation. Here is the calcification that corresponds to any of these. And of course, the histologic diagnosis is DCIS. No and no. This is neoductgenesis. 3D picture, conventional, and a mammogram. She was signed out as having a 5 mm invasive carcinoma and a 6 cm invasive carcinoma, which was erroneously called DCIS. No, dear colleagues, this patient had 2 invasive cancers, and this one determines her outcome, not this one. She died in 3 years. It happens very seldom nowadays that autopsy takes place, but please note, here's the desmoplastic reaction, here is the calcification, what was seen on the mammogram, and here is the lymphocytic infiltration. So she died from DCIS, not from the tiny non-calcified stellate lesion. Here are other images of her lung. Our research results, stretching from 1977 up to date, as well as these case demonstrations, should teach the pathologists to think over and the researchers who don't understand the term DCIS. And the remaining imaging biomarker is erroneously called invasive lobular carcinoma. Dear colleagues, it cannot originate from the lobule because when it originates from the TDLU, it's convex. This one is concave. When it originates from the major ducts, then it has calcification. This doesn't have calcification. Its clinical, histologic, immunohistochemical biomarkers are significantly different, those originating from the TDLU and those originating from the duct. It must come from a different site. There is no early phase. Once again, the stem cell carcinoma. And our research proved that it's the hybrid cells within the mesenchyme that become fake epithelial cells. The pathologist believes this is an epithelial cell. It looks like it's like a wolf in sheep's clothing. That's why it's E-caterin negative. That's why 40% of them die. That's why radiation, chemotherapy, does not influence the outcome. Our article was quite recently published in Molecular Sciences, a high-quality, high-impact factor journal. Does diffusely infiltrating lobular carcinoma of the breast arise from the epithelial mesenchymal hybrid cells? We proved it very nicely. And the answer is yes. The mesenchyme normally looks like this. This is the normal structure of the breast. But this one is too much. The hallmark of this breast cancer of mesenchymal origin is the enormous, excessive amount of fibrous tissue. The pathologists always talk about the cells, but please look at the red background and look at this spider's web appearance. Very different from stellate or circular lesions or calcified DAB. And it's a nightmare for the radiologist because all of this is carcinoma. Shown very well on automated breast ultrasound handheld as well as on MR, but easy to miss on the mammogram. And we cannot find it early. The entire structure of the breast participates in the malignization process. It shrinks the breast. An adenocarcinoma of the breast causes focal skin thickening and retraction. This is thickening. Huge difference. Three-dimensional histology beautifully shows everything that is colorful here is carcinoma. It is not a mammogram, but it's the ultrasound that is the procedure of imaging choice. Concave, 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 three-dimensional image. A true nightmare for an oncologist as well. But you cannot call it invasive lobular carcinoma and 30-40% risk of dying from breast cancer. This is a stem cell, and this is a stem cell carcinoma. BCMO, received post-op radiation or not? Received chemotherapy or not? What's the difference? None. We are so happy that out of those who were destined to die, we cut back in one single generation of physicians by 50%. But if you are intellectually honest, you ask the question, why do women still die from breast cancer? You really have to take the anatomic site of origin into account. You have to use MR and all the other tools to distinguish between unifocal, easy to handle and detect, multifocal, not easy to detect and handle, and diffuse, hopeless breast cancers. Take-home message, large tumors, which should not happen in the 21st century. They don't come to screening. Multifocal cancers, TNM classification makes a mistake by asking for the size of the largest focus when the tumor burden is this big. And diffuse cancers. These are the three that are responsible for the other half that is still dying from breast cancer. Unifocal cancers, about 40% of all breast cancers. Multifocal AABs and diffuse cancers. And the fatality rate is 2.2 times, 2.9 times higher in these. That's where, dear colleagues, we have to put our efforts and the focus on. Our research group spent a lot of time and effort examining whether the molecular biomarkers are going to help in predicting the outcome. And we found the following. Definitely in unifocal breast cancers, unifocal AABs, but that's not the majority of the cases. If a stellate lesion 1 to 14 millimeter has as much as 95% estrogen receptor positivity, then I would expect this outcome, and indeed I get this outcome. But look at the BCMO. Here as well, 93% estrogen receptor positivity, so I would expect that the red lines are here. No, they are not. What a disappointment. I don't get what I expect when I look at the estrogen receptors. When I look at the progesterone receptors, HER2, Ki67, what a disappointment. In stellate and circular lesions, even if they are somewhat larger, you can trust the immunohistochemical biomarkers, but don't trust it ever, individually or in combination. And indeed, we went back 4 decades, and decade after decade, whatever promise Big Pharma came up with, improved treatment, it just doesn't work on the diffuse carcinomas. Once again, post-op radiation or chemotherapy doesn't help. We can trust the combination of the ER-PR, HER2, called luminal A, luminal B. Most of the small or larger stellate circular lesions are luminal A. In the cancers originating in the major ducts or from the mesenchyme, 53% and 81% are luminal A. Fooling the oncologist, this is a good cancer. No, it's a wolf in the sheep's clothing. The only positive thing is that I look at the imaging biomarker, and I know this is a bad actor. I look at the imaging biomarker. It's a bad actor. Conclusion? Do not even determine or spend your money on those cases that have this kind of imaging biomarker. You will be fooled, You are going to overtreat the patient. They are going to suffer from the side effects of chemo, which brings in zero benefit. Using the imaging biomarkers, I can distinguish those that have superb outcome, very good outcome, very dismal, and even more dismal outcome just by looking at the mammogram. Oncologists, pathologists, surgeons, it's not so difficult to learn the imaging biomarkers. And that's the role of the tumor board, to point out the bad actors. Our role is to cut back on mortality on the multifocal and the diffuse cancers. Look at the mammogram, and it tells you exactly which one is the bad actor. Progress in breast diagnosis and treatment, which we really want to accomplish, will largely depend on changing the outmoded, anatomically incorrect and harmful terminology of histopathology and the chopped onion type 200 years old small section histology. The immunohistochemical biomarkers, molecular biomarkers, can never compensate for a failure to use large format histopathology technique and maintaining the old-fashioned, anatomically incorrect histopathologic terminology. That's why our tumor board looks like this. Constant, large format, thin section, large format, thick section, histologic breast imaging correlation, and image-guided histopathology. It happens seldom that somebody shows you 39-year survival curves. This kind of enormous distinction when concerning outcome between the AABs and the less controllable BCMOs and DABs, you would never be able to accomplish just by looking at a conventional histology finding and the molecular biomarkers. That's why I'm saying, please introduce and integrate the imaging biomarkers to your everyday practice. That's exactly what the new approach offers and asks from all of us. Thank you very much for your attention.